Hi, I'm Tom. I'm here with Valentina and Wendy to discuss ethical dilemmas relating to healthcare data science. The purpose of this interview is to promote awareness and appreciation of the healthcare that providers provide, how data science helps and doesn't help providers, and ethical dilemmas in healthcare data science. I would like to have each of us introduce ourselves. I'm Tom, a graduate student of data science at the University of Virginia. This interview serves as my final project for the course, Ethics of Big Data.
So I'm Valentina Baljak. I'm a senior data scientist at UVA Health, and I work a lot with health system data and data related to patient care.
And I'm Wendy Paulton. I have about 10 years of experience in healthcare, both as a nurse and now as a data scientist. I've been working in data science for about 5 years.
Before we consider topics like vulnerability and balancing information disclosure, do you have any general thoughts around ethics or ethical dilemmas as it relates to healthcare data science?
Well, a lot of the ethical healthcare questions and topics are not just specific to data science, of course. Right away, my mind goes towards end-of-life care, care for people that maybe don't have decision-making authority, care for people who are sensitive to other or have other social needs, or under-resourced patients and so forth.
We probably share a lot of that, those dilemmas, and go into similar directions. I would just add that most recently, my big concern is the transparency towards the patients, all of them. Like if you're using these new tools like AI in the patient care, how much do we need to tell patients to actually consider them informed in the decision making, and how much they need to be involved in knowing how these tools are used in their care.
Right. And then I always think about the end result of those algorithms. Do people really want to know if their life expectancy is less than they think? Maybe not.
Maybe we can revisit the idea of providing the right balance of information later on. I'd like to turn to the purpose of healthcare data science first. Data scientists improve patient outcomes by informing providers and, by extension, patients of the experiences of patients. AI these days should offer insights, reminders, and re-emphases and support rapid information access. According to an article called Algorithmic Injustice, tech policy advisor Theodora Skaidas and data science consultant Abner Colon, AI shouldn't supplant clinical decision making. Data is complex in terms of source, quality, and meaning. Models are unpredictable and necessarily biased. Making decisions relies in part on context, wisdom, and relating. Maybe we can now turn to balancing information disclosure. Considering a different article called Seeing Without Knowing, this article calls data scientists to produce machine learning algorithms that automatically avoid discriminating against users and automatically provide transparency to users, which provides insight and governance. But there are questions about providing information that is just right or too little or too much with individuals with possibly different cultures. Do you have reflections?
What I've seen in my work, definitely every aspect of using data to treat an individual can make them vulnerable. People are not statistics. Each individual, like we can't apply the rule that 90% of the patients will experience this to that particular individual. 90% of patients experiencing something doesn't mean that that particular person has 90% chance of experiencing that. So we really need to be careful about how we curate data. Does that outcome of our model really truly reflect this individual as well? Which is why I also support that, thinking that all of these are tools and should be used as tools with the discretion of someone who really understands how the tool works and what they're getting from that. So it's a decision support rather than decision-making process. The ethical dilemma, of course, is this individual reflected in what we have built, and how well they have been reflected in that, and how much we can actually explain that to the patient.
Right. Right. Epic, one of the health record giants, has recognized the need for equitable algorithms. They've come out with a tool called Seismometer, where data scientists can review an algorithm's efficacy for subpopulations. So, we traditionally were looking at the whole pool, and then we want to split it out by gender or age groups. We can do that. One of the challenges that data scientists have, though, is that you really have to have a large number of records in order to do machine learning and to work with generative AI. So if you dissect your patient population too much, you really don't have enough patients to come up with a meaningful model. So that's an ongoing process. People have gotten around that through using synthetic data and using national, publicly available data sets and registries and things like that. But it's a continual challenge to have enough patients where you can look at the subpopulations. And the other problem is if you build a model for a micro group, it may be overfitted. You may have something that only works for a few people, and you want your tool to be as generalizable as possible.
We have experienced something like that exactly with a model that kind of predicts, and it's tried and tested model that looks at the patient deterioration, and we have discovered that it doesn't even work with the different population in the same hospital, say medicine versus cardiology.
Too, I think a lot of healthcare institutions, ours included, have put governance councils in place to review the model development process and make sure that we are considering bias and trying to build models that aren't just for males or whatever, that we consider different subgroups.
I think I'd like to turn to the vulnerability section and consider questions like, how are patients vulnerable, and how should providers relate to vulnerable patients? What are ethical dilemmas here? I guess I thought that Valentina shared was that in ethics and in healthcare, there are lots of questions. And I'm curious about how professionally you relate to the fact that there are lots of questions and a lot of dialogue that need to happen. And then maybe we can consider these questions particularly related to vulnerability.
Well, initial thoughts on that are that AI is never intended to replace a human being, and so it's important to have a human in the loop somehow, and that as physicians are being trained, or whatever practitioners being trained to use AI to help screen patients or diagnose patients, that they do still critically review even the AI scores. The advantage, of course, to using artificial intelligence is that you may have a broader scope of data that is automatically processed and put at the forefront, whereas before it would take hours to review charts and things to come up with the same information. And you may know it sooner, but we still have to have a human in the loop.
Looking at what's written in our outline here, I actually would trust machine learning model to do the surgery more than I would trust machine learning model to create a decision that the surgery is necessary. Surgery can be programmed more precisely. There are way fewer variables there that machine can't actually learn and know than there are in deciding whether the surgery is necessary or not, like less ambiguous. So that's one of the dilemmas, is how much information can we provide to the patient and call them informed. Patient may not have enough background to understand that. Patient may not have enough capability at the time of distress to understand and process the information we are giving them. So one of the things, I can actually give this my personal example. When I did the LASIK surgery, the doctor who did the LASIK surgery had also a degree in computer science. So at the time, he was able to explain to me both sides, like the medical side of the things and also how the machine works. And
Awesome.
I felt way more confident that this is something I wanted to do. And as Wendy mentioned, there has to be a human being in the loop. I needed that doctor to explain all of these things. I don't think I would be as eager to accept that decision if it was just presented to me from a machine learning model itself.
You also have, I think, a great need to include human beings in the model development part too. You can build a whole model just on clinical symptoms if you're trying to predict a particular comorbidity or presence of or potential development of. You could also build a whole model just on like hospital process things, like how long it took to get from point A to point B. And some of those things have nothing to do with the patient. You could build a whole model on the history of a person or future desires and goals or care available when they get home from the hospital. So having people who understand all that is crucial to building good models.
I think at this point, I'd like to turn to a conclusion and re-emphasize that context and relating are very important. And healthcare data science improves patient outcomes by allowing providers to quickly access information and resources. There are many questions still to be asked and answered and fleshed out in modern medical practice relating to patient vulnerability and information disclosure. Do you have any final thoughts?
We haven't even scratched the surface of all the potential dilemmas and at each factor. So we talked about the patient vulnerability and the data sourcing and model accuracy here. So in that particular scope, I would say the takeaway is these are tools, these are good tools, and they should be used as such. And the good tools can only be wielded by the educated provider, by the educated user, basically. So I believe we have just opened the box. We haven't really answered much. So from there, it's our responsibility as data scientists to make sure that we explain what we are doing in the best possible way to the people who are going to use what we are building. And then it's all of our responsibility to protect that ultimate user, which is the patient.
Yeah. And I would say too that there's a lot of fear out there, both among clinicians and among patients, about what AI is and what it could do. And to that, I would say that it's a tool. I'd echo what Valentina said, it's a tool. And why not use it to its fullest advantage? And also, I would say that not everyone is fully aware of this, of course, at all times, but in my own work experience, I know people who are intimately involved in trying to be as fair as possible and to use the best information possible and to help people quicker than we did before. So it's not a big bad monster. It's a good thing.
I hope this was informative on how to practice healthcare data science ethically, and thanks for your time.
Thank you.
Thank you.